A 27-year-old woman with history of repeated mid-trimester pregnancy loss. During evaluation, hysterosalpingography was performed and it revealed 2 uterine cavities. MRI was performed to clarify the diagnosis. What is the diagnosis? Mention 2 other methods to clarify the diagnosis. What is the treatment? In the female embryo, internal genital organs develops from 2 Mullerian ducts. The caudal portion of the Mullerian duct fuse to form uterovaginal canal. The septum between the 2 Mullerian ducts is reabsorbed, forming a single cavity. The fused part of the Mullerian duct will form the uterus, cervix, and the upper vagina, while the unfused portion will develop into fimbria and fallopian tubes. Partial failure in fusion results in bicornuate uterus, which may be complete or incomplete, while failure of resorption will result in a septate uterus. Bicornuate uterus account for about 10% of Mullerian duct anomalies. The condition usually remains undiagnosed until cesarean delivery or other procedures reveal its existence. Hysterosalpingography will reveal 2 uterine cavities. However, this could be a bicornuate uterus or a septate uterus. 3D ultrasound or MRI are required to differentiate between the 2 conditions. Surgery in the form of metroplasty is rarely performed. It is best reserved for women with recurrent pregnancy loss and no other identifiable cause. Strassman in 1952 described a surgical technique that unified 2 equal-sized endometrial cavities. Make an incision in the intervening uterine wall. Reapproximate the posterior uterine wall. And after reapproximation of the posterior uterine wall, start to reapproximate the anterior uterine wall. There are 2 main disadvantages of this operation. Firstly, there is a high rate of postoperative pelvic adhesion, leading to a subsequent infertility. In addition, it requires cesarean delivery in subsequent pregnancy to prevent uterine rupture. Septate uterus is the most common congenital uterine anomaly, and it accounts for about 55% of all Mullerian duct anomalies. Fertility doesn't appear to be substantially compromised in patients with septate uterus. However, this anomaly is associated with the poorest obstetric outcomes of all Mullerian duct anomalies. Again, hysterosalpingography and 2D ultrasound are not helpful in differentiation between septate and bicornuate uterus. 3D ultrasound or MRI are required to differentiate between the 2 conditions. But why HCG is not helpful in differentiation between septate and bicornuate uterus? Here we can see a bicornuate uterus and a septate uterus. During hysterosalpingography, we inject a radio-oblique dye inside the uterine cavity. Then we perform X-ray. X-ray will visualize the oblique dye inside the cavity, but will not visualize the outer contour of the uterus. So I will remove the uterine wall from the picture. Now, it's clear that hysterosalpingogram is similar between bicornuate and septate uterus. 3D and MRI, on the other hand, can examine the internal contour and external contour of the uterus. American Society of Reproductive Medicine, ASRM, and ESHRI in 2016 published guidelines for differentiation between the 2 conditions using 3D ultrasound or MRI. In ESRM 2016, we drew the interosteal line and measure the distance below the interosteal line and call it internal indentation. We measure the angle of internal indentation and measure the external indentation if present. The diagnosis is a uterine septum if internal indentation is 1.5 cm or more. Angle of internal indentation less than 90 degrees and external indentation less than 1 cm. The diagnosis is bicornuate uterus if external indentation more than 1 cm. In Ashley 2016, we measure internal indentation, external indentation, and uterine wall thickness, which is the thickness above the interosteal line. The diagnosis is a uterine septum if internal indentation more than 50% of the uterine wall thickness, external indentation less than 50% of the uterine wall thickness, and the diagnosis is bicornuate uterus if external indentation is more than 50% of the uterine wall thickness. Here is our case study. The internal indentation is more than 1.5 cm. Angle of internal indentation is less than 90 degrees. And actually there is no or very minimal external indentation. So the diagnosis is a uterine septum. Regarding treatment of uterine septum, hysteroscopic septum resection can improve live birth rates and clinical pregnancy rates in women with recurrent pregnancy loss and infertility.